When you look at a classic gastric adenocarcinoma on an endoscopy, the pathology is just, it's aggressively apparent.
Oh, absolutely. It's like looking at a blasted landscape.
Right, exactly.
Yeah.
Deeply ulcerated, necrotic edges, chaotic vascularity. You know exactly what you're dealing with the second the image hits the monitor.
Yeah, the structural disarray is just impossible to miss. I mean, the malignant architecture basically screams at you, and the surgical mandate is pretty clear from that very first visual impression.
But then you step into the world of gastric neuroendocrine tumors, and suddenly the presentation becomes almost deceptive.
Extremely deceptive, yeah.
Like the stomach lining might just look, well, slightly nodular. You might see a few sessile polyps in the fundus. And if you're the endoscopist holding the scope, it can look infuriatingly subtle.
Very much so. It's easy to dismiss if you aren't vigilant.
But underneath that subtle mucosal disruption, you're looking at a highly complex microscopic factory that might be pumping out vasoactive hormones, or worse, a silent genetic cascade that's preparing to invade the muscularis propria and metastasize.
Exactly. And the clinical danger really lies in that exact subtlety. I mean, these tumors are a complete masterclass in how underlying pathophysiology directly dictates biological behavior.
And ultimately the surgical strategy, right?
Yes, precisely. You cannot successfully resect or medically manage these tumors without a molecular level understanding of their origins. It's just not possible.
And so that is exactly our mission for this deep dive. We are taking a high-level, rigorous exploration of gastric neuroendocrine tumors, or GNETs, for you listening today.
It's a massive topic, but so crucial.
It really is. So whether you are a senior surgical trainee actively prepping for the FRCS exam, or maybe a PhD researcher investigating gastroenterological pathology, this discussion is designed specifically for you.
We're not doing a basic overview here.
No, we are skipping the basics. We're getting straight into the cellular machinery, the WHO 2022 diagnostic criteria, and the precise surgical and medical management pathways.
Which is really where the clinical battle is won or lost.
Right. Okay, so let's unpack this. We have to start with the fundamental biological engine for the most common types of GNETs, which is the endochromaffin-like cell, the ECL cell, and its specific relationship with gastrin.
Yeah, the ECL cell's baseline physiology is the foundation of literally everything we are about to discuss.
Because it's a neuroendocrine cell, right?
Yeah.
Situated in the oxyntic mucosa of the fundus and the body.
Right, and its primary role there is to synthesize and secrete histamine, which then acts in a paracrine fashion on the H plus K plus ATPase pumps of the nearby parietal cells.
To drive acid secretion.
Exactly, it drives the acid. But for types 1 and 2 GNETs, the driver of the neoplastic transformation isn't the histamine, it's unequivocally gastrin.
Gastrin binds directly to the CCK2 receptors on those ECL cells.
Yes, and it acts as a highly, highly potent trophic factor. It tells the cells to grow.
So given that type 1 GNETs are tied to autoimmune atrophic gastritis, and they make up, what, 70 to 80% of all cases?
Yeah, about 70 to 80%. They're by far the most common.
Does the patient demographic skew heavily toward populations that are already prone to autoimmune disorders?
Oh, massively. We see a huge predilection for middle-aged women, typically presenting with a 2-to-1 female-to-male ratio.
Wow, okay, 2 to 1.
Yeah, and the mechanism there is purely autoimmune. You have this CD4 plus T-cell mediated destruction that specifically targets the H plus K plus ATPase pump.
The proton pump itself.
Right, the pump itself, and also intrinsic factor.
So if those choroidal cells are systematically destroyed by autoantibodies, the oxyntic mucosa basically undergoes severe atrophy.
Complete atrophy, yes.
Which means you develop profound achlorhydria, the stomach can't make acid.
Exactly. The intraluminal pH of the stomach spikes. It becomes highly alkaline.
And this is where the normal negative feedback loop completely disintegrates, right? Like normally a low pH stimulates antral D cells to release somatostatin.
Which then inhibits the antral G cells. That's the normal brake on the system.
But with chlorhydria, the stomach is alkaline, so that somatostatin brake is just removed entirely.
It's totally gone. So the G cells in the antrum are now completely uninhibited.
They just run wild.
Basically, yeah. They respond to that alkaline environment by releasing massive, continuous quantities of gastrin right into the systemic circulation.
It's like a broken thermostat. The stomach gets cold, quote unquote, because there's no acid. So the heater, the gastrin, kicks on and just never shuts off, essentially melting the whole system.
That is a perfect analogy. This relentless hypergastrinemia constantly bombards those CCK2 receptors on the ECL cells we talked about.
And intracellularly, what happens? That activates the phospholipase C pathway, right?
Spot on. It activates phospholipase C, leading to intracellular calcium spikes and downstream MAP kinase pathway activation.
Which drives the continuous cellular proliferation.
Right, and it progresses linearly. First, you just get simple ECL cell hyperplasia.
Just an overgrowth.
Exactly. Then, as the decades of this hormonal bombardment continue, it evolves into dysplasia and finally, full neoplastic transformation.
The birth of the type 1 GNET.
Exactly.
But I want to push back on a clinical paradox here, because this always trips people up.
Sure, go for it.
We prescribe proton pump inhibitors, PPIs, with incredible frequency. I mean, millions of people are on them.
Every single day.
And their pharmacological intent is to shut down that exact same H plus K plus ATPase pump.
To stop the acid. Right.
So if chronic PPI therapy induces a lack of acid, which subsequently spikes gastrin, aren't we risking tumors? Why aren't we seeing a massive population-level epidemic of type 1 GNETs in every patient on long-term omeprazole?
That's such a common question, and it's a really critical distinction to make, particularly when you're evaluating a patient's history.
Right, because the mechanism seems identical on the surface.
It does, but the hypergastrinemia induced by PPIs is fundamentally different in magnitude and consequence than the hypergastrinemia you see in autoimmune gastritis.
How so?
Well, while long-term PPI use does block acid secretion and leads to a compensatory rise in serum gastrin, the actual parietal cell mass is still totally intact.
Oh, I see. It hasn't been destroyed by autoantibodies.
Exactly. In fact, it often hypertrophies. The achlorhydria from a PPI is pharmacological and often intermittent, right? It's not an absolute anatomical destruction of the cells.
So the gastrin levels peak, but they just don't reach those astronomical sustained plateaus that you see in complete autoimmune destruction.
Right. The levels are elevated, but not to that same extreme. And furthermore, for a true type 1 GNET to develop, you almost universally need that underlying severely inflamed and atrophic mucosal microenvironment.
The actual damage to the stomach lining itself.
Yes. The inflammatory cytokines and the altered local tissue architecture in autoimmune gastritis provide a necessary cofactor. It's that milieu that allows the hypergastrinemia to push the ECL cells from simple hyperplasia into actual dysplasia and neoplasia.
So mere pharmacological suppression lacks that chronic inflammatory milieu.
Exactly. You don't get the tumors just from the PPI alone.
Okay, that makes perfect sense, and that perfectly sets up our pivot to type 2 GNETs, which are the syndromic variant.
Right, a very different clinical picture.
Much rarer, right? Comprising only maybe 5 to 6% of cases with an equal sex distribution.
Yeah, very rare.
And in type 2, the engine is still gastrin, but the physiological context is completely inverted. The patient doesn't have achlorhydria. Actually, they often have massive acid hypersecretion.
Right. In type 2, the hypergastrinemia is entirely independent of the stomach's internal feedback loops.
It's coming from outside the stomach.
Exactly. The gastrin is being autonomously secreted by a rogue primary gastrinoma, typically located in the duodenum or the pancreas.
Which is the classic Zollinger-Ellison syndrome, or ZES, presentation.
Spot on. So this gastrinoma floods the systemic circulation with gastrin.
And it binds to the intact parietal cells in the stomach.
Yes, driving them to produce absolute oceans of acid, which causes the severe refractory peptic ulcer disease that's so characteristic of ZES.
Man, oceans of acid. But simultaneously, that exact same massive gastrin load is binding to the CCK2 receptors on the ECL cells.
Doing exactly what it did in type 1.
Right, driving the exact same hyperplastic to neoplastic sequence. But with type 2, you have the added complexity of multiple endocrine neoplasia type 1, the MEN1 genetic mutation.
That's the kicker. The MEN1 gene, which is located on chromosome 11q13, codes for the protein menin.
And menin acts as the tumor suppressor, right?
It does. It's a crucial tumor suppressor involved in chromatin remodeling and transcription regulation. So when you have a germline mutation causing a loss of heterozygosity at this locus, the ECL cells are already genetically primed for uncontrolled growth.
So it's essentially a two-hit physiological disaster.
It's a total disaster.
The cells are being externally driven to multiply by the gastrinoma, and their internal genetic braking mechanisms mediated by menin are completely missing.
Right. Which perfectly explains why type 2 GNETs, while they are still generally well differentiated, possess a slightly higher proliferative capacity.
And a noticeably increased risk of local invasion and metastasis compared to type 1, right?
Yes, exactly. The underlying genetic instability essentially accelerates the neoplastic timeline.
Okay, now, if type 1 and type 2 are essentially slaves to this gastrin feedback loop, either endogenous or exogenous, How do we approach type 3 GNETs?
Oh, type 3 is a whole different animal.
Because type 3 is an entirely independent sporadic beast. They represent roughly, what, 15 to 25% of cases?
Around there, yes. Typically arising in older patients, usually between 50 and 70 years old.
And their defining biological trait is that they're completely gastrin-independent.
Completely. They arise de novo.
Meaning there is no background of atrophic gastritis, no gastrinoma, no hormonal drive whatsoever.
Right, and what's fascinating here is that the lack of gastrin-dependency forces us to view type 3 through a strictly oncogenic lens.
Because they aren't relying on the CCK2 receptor pathway to grow.
Exactly. Their genesis is driven purely by aggressive somatic mutations.
What kind of mutations are we looking at for the researchers listening?
We see profound alterations in major tumor suppressor pathways. For instance, the TP53 gene, which is responsible for cell cycle arrest and apoptosis in response to DNA damage, is frequently mutated.
So the cells basically lose their self-destruct mechanism when their DNA gets damaged.
Precisely. You also see dysregulation of the RB1 pathway and alternative lengthening of telomeres, the ALT pathway.
And the ALT pathway grants these cells essentially limitless replicative potential, right? Immortality.
Exactly. It's a highly dangerous molecular profile.
So if you are an FRCS candidate listening to this, the clinical implication of that gastrin independence is absolutely massive.
Huge. It changes the entire presentation.
Without meeting a disuse hormonal signal like gastrin to grow, these tumors don't present as multiple small, polite little polyps scattered all across the fundies.
No, they don't. They present as solitary, aggressive, rapidly dividing masses that drive deep into the gastric wall.
Just a single, ugly, invasive mass.
Yes. The local invasion is often profound. They utilize matrix metalloproteinases to rapidly degrade the basement membrane.
Eating right through it.
Exactly. And they rapidly infiltrate the submucosa and the muscularis propria. So by the time a type 3 is actually diagnosed, the rate of regional lymph node involvement and even hepatic metastasis is exceptionally high.
Which means looking at these different types under a microscope reveals entirely different architectures and aggressive potentials.
Night and day differences.
And this brings us right into the histopathology, specifically the WHO 2022 classification criteria.
A very crucial area for any senior surgeon or pathologist.
Let's start with the baseline immunohistochemistry, because just proving the lesion is neuroendocrine in the first place requires specific stains, right?
It does. The diagnostic triad for neuroendocrine differentiation relies on three main markers: chromogranin A, synaptophysin, and CD56.
Walk us through what those actually are.
Sure. So synaptophysin is an integral membrane glycoprotein found in the small presynaptic vesicles. It is highly sensitive for these tumors.
Okay, and chromogranin A.
Chromogranin A is found in the large, dense core secretory granules. Now, it is slightly less sensitive than synaptophysin, but it's highly specific.
So if a pathologist is looking at nests or tuberculae of uniform, round to oval cells with amphiphilic cytoplasm, and they light up with these stains, the neuroendocrine nature is locked in, confirmed.
Confirmed, yes. But here's the clever part. You can also use immunohistochemistry to hint at the specific type of GNET you're dealing with.
Oh, because of the gastrin receptors.
Exactly. Because types 1 and 2 are fundamentally gastrin-driven, the tissue will heavily express those CCK2 receptors.
You'll light up for CCK2.
Right. But type 3 GNETs being heavily mutated and gastrin-independent, they frequently lose the expression of those receptors entirely.
Oh, wow. So the stain itself helps differentiate the sporadic from the hormonal.
It's a huge clue, yes.
Yeah.
But identifying the tumor is only step one.
Right. Staging its aggression requires grading. And the WHO 2022 rules dictate this entirely via the Ki-67 proliferation index and the mitotic count.
Let's define those, because they are the bedrock of the classification. Let's do it.
The Ki-67 protein is strictly associated with cellular proliferation. It is present during all active phases of the cell cycle, so G1, S, G2, and mitosis, but it's totally absent in resting cells, the G0 phase.
So if the cell is resting, it won't stain for Ki-67.
Correct. Pathologists use the MIB1 monoclonal antibody to stain for it, which generates a percentage. We call this the labeling index.
Okay, so that's Ki-67. What about the mitotic count?
The mitotic count, conversely, is a direct, manual visual tally of cells actively undergoing mitosis within a defined area.
Traditionally 2 square millimeters, right?
Yes, 2 square millimeters. And they typically target the hot spots where the visual activity is the highest.
Okay, so breaking down the WHO 2022 grades for the listeners, Grade 1 tumors have a Chi-67 of less than 3% and a mitotic count of less than 2 per 2 square millimeters.
Very low grade, very indolent.
Grade 2 is a Chi-67 between 3 and 20%, or a mitotic count between 2 and 20.
The intermediate zone. And grade 3 is a Chi-67 over 20%, or a mitotic count over 20. But, and I want to pause here because I genuinely struggle to understand the clinical logic of the discordance rule here.
It's a controversial one for sure.
Right, because the WHO mandates that if the Chi-67 and the mitotic count suggest different grades, you absolutely must assign the classification based on the higher grade.
You always default to the higher grade.
But if Chi-67 immunohistochemistry is objectively more robust and reproducible than a pathologist just visually hunting for mitotic figures, which is subject to fixation artifacts, why do we default to the higher mitotic grade if it contradicts the Chi-67?
It feels counterintuitive.
It really does. Are we risking over-treating the patient based on a visual sampling error?
It is a point of frequent debate in multidisciplinary tumor boards everywhere, believe me. But it is rooted in a fundamental principle of surgical oncology. You must never underestimate a tumor's biological potential.
The better safe than sorry approach.
Essentially, yes. Neuroendocrine tumors are notoriously heterogeneous. I mean, you can have a largely indolent tumor that harbors highly aggressive subclones hidden inside it.
So a small patch of cells that are way more aggressive than the rest.
Exactly. So if a pathologist identifies a hotspot where the true mitotic figures push the tumor into a grade 3 category, even if the overall Chi-67 averages out to a grade 2, that aggressive subclone dictates the patient's ultimate prognosis.
So it's less about the mathematical average of the whole tumor and more about identifying the most dangerous fraction of the tissue.
Right.
If even a small sector of the tumor is acting like a grade 3, you have to treat the whole patient as having a grade 3 threat.
Because that subclone is the part that will metastasize and kill the patient.
That makes total sense.
Right.
I like thinking about the Chi-67 and mitotic count, not just as a speedometer, which is, a bit simplistic.
Right. It's more nuanced than that.
It's more like intercepting communications about an opposing army's supply lines. Like the mitotic count tells you how many soldiers are actively crossing the border right now.
I like that.
But the Chi-67 index tells you how many massive weapons factories are fully staffed and running at peak capacity just behind the front line. It reveals the imminent reproductive potential of the tissue.
That captures the dynamic perfectly. The Chi-67 shows what it's capable of doing very soon.
Exactly.
And we should note, the WHO classification also heavily differentiates between a well-differentiated grade 3 neuroendocrine tumor, or NET, and a poorly differentiated neuroendocrine carcinoma, or NE.
Right, an NEC. And an NEC is not simply a high-grade NET, right? It's completely different.
It is a genetically distinct entity. Morphologically, an NEC totally lacks those organoid nests and trabeculae we talked about earlier.
What does it look like instead?
It actually resembles small cell or large cell carcinoma of the lung. Just sheets of highly pleomorphic cells with extensive necrosis, massive nuclear atypia, and a Chi-67 that frequently exceeds 50 or even 80%.
Oh, wow, 80%. That's incredibly aggressive.
Highly lethal.
So if you are the surgeon assessing the patient, how do you correlate these microscopic horrors with the actual clinical presentation? How do we hunt these down and stage them?
That's the next logical step.
Because many of these GNETs, especially types 1 and 2, are entirely asymptomatic, right? They're found incidentally during an endoscopy for vague dyspepsia.
Exactly. When symptoms do manifest in types 1 and 2, they are rarely from the tumor itself.
What are they from then? The lack of acid?
Yes, they are from the underlying atrophic gastritis. Specifically, profound vitamin B12 deficiency due to the loss of intrinsic factor.
Right, because parietal cells make intrinsic factor and they've been destroyed.
Exactly. So that leads to pernicious anemia, glossitis, and peripheral neuropathy. You might also see signs of chronic, low-grade occult bleeding leading to iron deficiency.
Just a slow drip of blood loss.
Yes.
Contrast that with type 3, which behaves so aggressively. You're looking at mass effects there.
Oh, absolutely. Early satiety, significant unintended weight loss, severe epigastric pain, or overt upper GI bleeding like hematemesis or melena.
Coughing up blood or passing dark Tory stool.
Exactly. And if you have a patient presenting with refractory peptic ulcers that fail high-dose PPI therapy, or signs of hypercalcemia like nephrolithiasis, kidney stones, and bone pain.
Oh, that's the MEN1 connection.
Spot on. Your diagnostic algorithm should immediately pivot to evaluating for MEN1 and a type 2 gastrinoma.
Because the hypercalcemia means hyperparathyroidism, which is a hallmark of MEN1.
Exactly. The clinical suspicion really demands a highly specific biochemical workup, and the central axis of this evaluation is the fasting serum gastrin level coupled with gastric pH analysis.
That is the definitive fork in the diagnostic road.
It truly is.
Walk us through the fork. If the fasting gastrin is completely normal and you have a solitary invasive mass on endoscopy,
You are staring at a type 3. End of story.
right. But if the gastrin is elevated, you must ascertain the actual mechanism of that elevation.
Yes. Because if you are holding the scope and you see multiple polyps alongside a pale, thinned-out fundic mucosa completely devoid of rugal folds, you strongly suspect type 1.
But to scientifically prove it, you must perform a gastric pH aspiration during the procedure itself.
This step gets missed so often, but measuring the basal acid output and maximal acid output is definitive.
Because if the aspirated fluid pH is exceptionally high, meaning absolute achlorhydria, you have confirmed the broken feedback loop of autoimmune gastritis.
Right. The gastrin elevation is secondary to the lack of acid.
However, if the pH is less than 2, indicating massive acid hypersecretion,
Then the gastrin is primary. It is being illegally pumped into the system by a ZES gastrinoma.
right, an external source. And if the fasting gastrin is in that equivocal gray area, say between 200 and 1,000 picograms per milliliter, you utilize the secretin stimulation test.
A very elegant test.
Right. You'd administer exogenous secretin intravenously. Now, in a normal patient, or a type 1 patient, secretin naturally inhibits antral G cells, causing gastrin levels to actually drop.
Yes, that's the normal physiological response.
But gastrinoma cells possess aberrant secretin receptors. So when the secretin hits a gastrinoma, it paradoxically stimulates a massive, rapid release of gastrin.
Exactly. A spike of more than 120 picograms per milliliter above baseline confirms Zollinger-Ellison syndrome.
Incredible how backwards the tumor cells act.
It's biological hijacking.
So once the biochemical etiology is locked in, you move to local and systemic staging. Endoscopic ultrasound, or EUS, is mandatory for localized evaluation.
Absolutely mandatory. It provides high-resolution imaging of the 5 ultrasonic layers of the gastric wall.
And for types 1 and 2, what do you usually see on the EUS?
You typically see hypoechoic lesions strictly confined to the first 2 layers, the mucosa and the deep mucosa, or muscularis mucosae.
They don't dig very deep.
No, usually not. But EUS is critical for identifying exactly how deep a type 3 lesion has penetrated. Has it breached into the 3rd layer, the submucosa, or the 4th layer, the muscularis propria?
Which dictates the surgical approach.
Exactly. It also allows for fine needle aspiration of any enlarged regional paragastric lymph nodes.
Now, for systemic staging, standard multi-phase CT, or MRI, of the abdomen and pelvis is routine, obviously. But the absolute cornerstone of modern neuroendocrine staging is functional imaging.
The 68 dotatate PET scan.
The dotatate scan. The physics and pharmacology behind this scan are frankly remarkable.
They really are. It's targeted medicine at its finest.
You take a somatostatin analog, dotatate, which has an incredibly high affinity for somatostatin receptor subtype 2, or SSTR2, which is heavily overexpressed on the cell membranes of well-differentiated neuroendocrine tumors.
And then you attach gallium-68, which is a positron-emitting radioisotope.
So when injected, the tracer binds specifically to the tumor cells in the body.
Yes, wherever they are.
The gallium-68 undergoes beta plus decay. It emits positrons that basically immediately collide with electrons in the surrounding tissue.
Resulting in annihilation events.
Right, these annihilation events release paired gamma photons in exactly opposite directions. The PET scanner detects these photon pairs, physically mapping every single SSTR2 expressing tumor deposit in the body.
With exquisite sensitivity, too. Far surpassing standard CT scans, particularly for tiny occult bone or hepatic micrometastases that you'd otherwise totally miss.
It's literally lighting up the tumors from the inside.
It is. However, there is a vital clinical caveat here that trainees have to remember.
What's that?
The 68G dotatate scan relies entirely on receptor expression. If you are dealing with a poorly differentiated neuroendocrine carcinoma, a grade 3 NEC,
The ones that look like lung cancer.
right, those cells are so dedifferentiated that they have often lost their somatostatin receptors entirely.
Oh, so the dotatate has nothing to bind to.
Exactly. The scan will be falsely negative. You'll think the patient is clear when they are riddled with disease.
So for NECs, what do? You must switch to an FTG-PTCT.
Yes, utilizing fluorodeoxyglucose to highlight the aggressive, disorganized glucose metabolism characteristic of highly malignant tissue.
It highlights the sugar-hungry cells.
Precise.
And that receptor status, SSTR avidity versus FD avidity, acts as the direct bridge into the actual battle plan. The management pathways are just sharply divided based on this.
Totally dictated by it.
Let's start with the surgical and endoscopic management of localized disease. For type 1 and indolent type 2 tumors, the approach is highly conservative, isn't it?
Very conservative. If you have multiple type 1 polyps that are less than 1 centimeter and confined to the mucosa, standard practice is watchful waiting.
You just perform endoscopic surveillance every 1 to 3 years.
Exactly. The rationale there is that type 1 GNETs have an incredibly low rate of metastasis, typically less than 2%.
So subjecting an asymptomatic patient to a prophylactic gastrectomy for lesions that will likely never threaten their life is just surgical overkill.
It's massive overkill with huge morbidity. However, if a lesion grows beyond 1 centimeter, or biopsy shows a Chi-67 index creeping upward, you step up to local excision.
Using endoscopic mucosal resection, EMR, or endoscopic submucosal dissection, ESD. Now, ESD is technically demanding, but it's often preferred for lesions approaching 2 centimeters. Why is that?
Because it allows the endoscopist to dissect precisely through the submucosal plane. This achieves a much higher rate of en bloc resection, getting it out in one single piece with clear, deep, and lateral margins compared to piecemeal EMR.
So you know for sure you got it all.
Exactly.
But if we shift to type 3 GNETs, that conservative endoscopic rulebook is completely thrown out the window.
Oh, totally discarded.
Because type 3 behaves biologically like a classic gastric adenocarcinoma, the surgical intervention must match that level of aggression.
Absolutely. Even for small, localized type 3 lesions, the risk of microscopic nodal metastasis is substantial.
It's already in the lymph nodes, even if you can't see it.
Very often, yes. Therefore, the absolute standard of care is a formal oncologic resection.
Depending on the location of the tumor distal versus proximal, you're looking at a subtotal or a total gastrectomy.
Removing part or all of the stomach.
And crucially, you must perform a formal lymphadenectomy alongside it.
That's the most critical part.
There is ongoing debate between a D1 versus a D2 lymph node dissection, right?
There is, but clearing those regional nodal basins is non-negotiable for achieving a true R0 resection and accurate pathological end staging. You have to know if it's bred.
Now, if the disease has already escaped the regional nodes, if we're dealing with advanced, unresectable, or metastatic, grade 1 and grade 2 tumors, surgery basically transitions from curative to purely palliative, perhaps cytoreductive, just debulking the tumor.
Right. The heavy lifting then shifts entirely to medical management.
Which is heavily reliant on somatostatin analogs, or SSAs.
Right. If the dotatate scan confirms the metastases are strongly SSTR positive, octreotide or lanreotide becomes your frontline therapy.
These are the synthetic peptides that bind powerfully to the SSTR2 and SSTR5 receptors.
Exactly.
And intracellularly, how does that work? This binding couples with an inhibitory G protein, a G protein, right?
It does. This inhibits adenylate cyclase, which drastically reduces intracellular cyclic AMP levels and blocks the calcium channels.
So the whole cell just powers down.
Basically. The clinical result is a profound suppression of hormone secretion, immediately shutting down the VIP, serotonin, or excess gastrin that's causing all the patient's symptoms.
While also exerting a definitive anti-proliferative effect, actually arresting the tumor's growth.
It stops it in its tracks, for a time.
But the pharmacokinetics require absolute precision here. We use depot formulations for chronic therapy, right? Octreotide LAR, 20 to 30 milligrams, given intramuscularly every 4 weeks, or lanreotide autogel, 120 milligrams, given deep subcutaneously.
Right, the slow-release forms.
The LAR formulation works by suspending the drug in microspheres that slowly degrade in the muscle. But because of this, therapeutic serum levels are not reached for 10 to 14 days after the initial injection.
That is a critical danger window.
So you must bridge the patient with short-acting subcutaneous octreotide injections 3 times a day during that initial 2-week window.
Otherwise, they will suffer severe breakthrough symptoms. You can't just give the LAR and send them home.
Now, if the patient presents with severe carcinoid syndrome, which is rare for primary gastric tumors, but can occur with massive hepatic metastatic burden, and the diarrhea remains totally refractory to max-dose SSAs, we introduce telotrestat ethyl.
A fantastic drug.
It's a brilliant piece of targeted biochemistry. because carcinoid diarrhea is driven by the massive overproduction of serotonin from the tumor cells,
And telotrestat specifically inhibits tryptophan hydroxylase.
which is the rate-limiting enzyme in serotonin synthesis.
Exactly. It just cuts the supply line directly at the source. The cells can't make the serotonin anymore.
But what happens when the tumor inevitably finds a bypass pathway? Because they always do. When the disease progresses on SSAs, or if the tumor begins to lose SSTR avidity, we have to escalate to targeted therapies.
We do. We look at drugs like everolimus, which targets the MTORC1 complex, a critical node in cellular metabolism and angiogenesis.
And sunitinib, right? A multi-targeted tyrosine kinase inhibitor that blocks VEGF and PDGF receptors, essentially starving the tumor of its blood supply.
Yes. But the absolute apex of modern intervention for well-differentiated SSTR-positive disease is peptide receptor radionuclide therapy, or PRT.
PRT. We are talking about 177 Lu-dotatate.
It's like science fiction.
It really is.
Yeah.
You're taking the homing beacon of a somatostatin analog, the dotatate, and you're weaponizing it with lutetium-177.
The precision is astonishing.
Administered intravenously, the dotatate peptide docks with the SSTR2 receptor right on the cancer cell.
And the receptor is then rapidly internalized by the cell. It pulls the lutetium-177 directly into the cytoplasm.
Like a Trojan horse.
Exactly like a Trojan horse. And then lutetium-177 undergoes beta-minus decay. It emits high-energy electrons, beta particles that travel only a very short distance, typically less than 2 millimeters.
So this localized energy deposition causes catastrophic double-strand DNA breaks within the tumor cell, inducing apoptosis.
While that short path length severely limits the radiation damage to adjacent healthy tissue.
But there's also the crossfire effect, right?
Yeah.
Where it irradiates neighboring tumor cells even if they lack the receptors themselves.
Yes, the surrounding blast radius gets them.
But managing the infusion requires incredibly strict protocols.
You have to be meticulous.
You must hold the patient's long-acting SSAs for at least 4 weeks and short-acting SSAs for 24 hours prior to PRRT.
If you don't do that, the cold, non-radioactive SSAs that the patient is already taking will occupy all the SSTR2 binding sites.
They fill up all the parking spots.
Exactly. So the highly expensive, highly radioactive lutetium will just circulate harmlessly and be excreted renally, providing zero therapeutic effect.
Which brings us to the most difficult clinical scenarios of all: managing high-grade disease.
The hardest part of the job.
Grade 3 tumors are split clinically, well differentiated. Grade 3 tumors present a highly complex intermediate prognosis. They possess a high Chi-67, indicating rapid proliferation, yet they retain an organized architecture and often still express those somatostatin receptors.
So they're fast, but they still have the targets.
Right. So if a well-differentiated grade 3 has relatively low metastatic volume and strong dotatate uptake, you might still deploy PRRT.
You might, yes.
But if the disease is bulky or rapidly progressing, you have to transition to cytotoxic systemic chemotherapy. The most common regimen is CAP-TEM, capecitabine plus temozolomide.
An oral regimen, but a heavy hitter.
Capecitabine acts as an antimetabolite, inhibiting thymidylate synthase, while temozolomide is an alkylating agent.
And temozolomide works by methylating DNA, specifically at the O6 position of guanine,
which causes mismatched base pairs that lead to cell death.
Yes. However, its efficacy is directly countered by a cellular repair enzyme called MGMT.
The cell tries to fix the damage.
Right. So the genius of the CAP-TEM regimen is that capecitabine, given for a few days prior, is actually thought to deplete the tumor's MGMT reserves, leaving the DNA fully vulnerable when the temozolomide is finally administered.
It's a 1-2 punch.
Exactly.
But, and I want to highlight a critical sequencing danger here, and this is something that I initially found baffling until the underlying mechanism was explained to me.
The MDS risk.
Yes. If a patient is failing therapy, and you decide to give them CAP-TEM, you must rigidly check if they have previously received lutetium-177 PRRT.
You absolutely must.
Because if they have, you are stepping into a massive risk matrix. Why? How does that specific sequence cause such a high rate of secondary acute leukemia or myelodysplastic syndrome, MDS?
It all comes down to exhausting the regenerative capacity of the bone marrow. Lutetium-177 PRRT, despite being targeted, like we said, still circulates in the blood and delivers a low-dose radiation hit to the hematopoietic stem cells in the marrow.
Just from passing by.
Right. It causes sublethal DNA double-strand breaks. The marrow is stressed, but it survives.
Okay, so the marrow is weakened.
But then, if you hit that compromised marrow with an alkylating agent like temozolomide, which specifically attacks the DNA integrity of rapidly dividing cells.
You completely overwhelm the already taxed repair pathways.
Exactly. You induce catastrophic clonal hematopoiesis, frequently resulting in specific cytogenetic abnormalities like deletions of chromosome 5 or 7.
Which are the classic hallmarks of therapy-related MDS and acute myeloid leukemia.
You are effectively hammering the exact same fragile target with two highly mutagenic therapies sequentially. It requires an intense risk-benefit analysis by a highly specialized tumor board before you ever do that.
Incredible. And finally, we reach the apex of aggression, the poorly differentiated neuroendocrine carcinomas, the NECs. With the Ki-67 often pushing 80%, widespread early metastasis, and total loss of SSTR expression.
The prognosis is devastating, frequently a 5-year survival rate of less than 20%.
For an NEC, you must treat it with the same urgency and systemic protocols as a highly aggressive small cell lung cancer.
You don't have time to mess around. The frontline standard is aggressive, platinum-based chemotherapy, cisplatin or carboplatin combined with etoposide.
You are relying on the heavy cross-linking of DNA by the platinum agents to literally shatter the rapidly dividing cells.
It's brute force medicine, but it's all we have for NECs right now.
Wow. So to summarize this immense clinical journey for you all today, we define the gastrin-driven engine of types 1 and 2, tracing the precise feedback loops broken by autoimmune and ochlorotide or hijacked by a ZES gastrinoma.
Right.
We explored the sporadic TP53 and RB1 mutated nature of type 3. We dissected the WHO 2022 Ki-67 criteria and the surgical philosophy behind the discordance rule.
A lot of ground covered.
And we mapped the divergent therapeutic pathways from the precision of ESD for mucosal lesions to the targeted nuclear strike of PRRT and the systemic devastation of platinum therapies for NECs.
The entire field basically relies on exploiting the specific biological liabilities of the tumor subtype.
But, and this is where I want to leave our listeners today, there's a frontier beyond the platinum therapies, particularly where those toxic regimens are failing to provide durable responses in high-grade NECs.
Oh, this is the really exciting stuff. We connect this to the bigger picture.
Right. And that leads us to a fascinating area of emerging science for you to explore on your own. Because many of these highly aggressive, high-grade tumors demonstrate a high tumor mutational burden, or they display profound microsatellite instability. They're MSI high.
Yes. In an MSI-high tumor, the DNA mismatch repair proteins like MLH1 or MSH2 are fundamentally broken.
So as the tumor rapidly divides, it accumulates thousands of unchecked mutations.
Exactly, leading to the production of abnormal, alien-looking proteins called neoantigens right on the cell surface.
Now, ordinarily, the host's cytotoxic T cells would instantly recognize these neoantigens and just obliterate the tumor.
But the tumor adapts. It's smart. It upregulates immune checkpoint proteins like PD-L1, which bind to the PD-1 receptors on the T cells, effectively causing T cell exhaustion.
It blinds the immune system.
Totally shuts it down.
This is exactly where immune checkpoint inhibitors like pembrolizumab enter the battlefield. Pembrolizumab is a monoclonal antibody that blocks that PD-1 to PD-L1 interaction.
It literally strips the blindfold off the exhausted T cells.
For patients with MSI high-aggressive neuroendocrine carcinomas, this represents a radical shift in strategy. Instead of trying to poison the tumor with toxic platinum agents, we are unblinding and unleashing the patient's own immune system to hunt the cancer down.
It is an incredible paradigm shift. Tracking the clinical trial data on immune checkpoint inhibition in neuroendocrine neoplasms is absolutely essential for anyone wishing to stay at the cutting edge of oncological research.
The potential to turn a universally fatal diagnosis into a manageable immune-controlled state is the holy grail of current research.
It truly is the future.
It's a phenomenal area of active investigation. We want to thank you for diving into the extreme depths of gastric neuroendocrine pathology with us today. Whether you are walking into the operating theater, analyzing stains at the bench, or sitting for your surgical exams, keep questioning the molecular mechanics, keep challenging the clinical protocols, and keep pushing the boundaries of your knowledge. We'll see you next time.